Osteoarthritis is more of a wear and tear arthritis that that affects your joints, although there can be a hereditary component with it, whereas rheumatoid arthritis is an autoimmune inflammatory arthritis that attacks the tissues of your joints. When we take a look at the symptoms of rheumatoid arthritis, it's joint pain, it's tenderness of the joints, swollen joints, and significant morning stiffness. Now, oftentimes with osteoarthritis, you will have morning stiffness, but it's brief. It might only last for 10 or 15 minutes and then you get going. But with rheumatoid arthritis, it can last hours. And it's very debilitating, and by the time you start to feel better, possibly hours have gone by, and then you're a little bit better through the day until you sit down again and re-stiffen. And that's pretty much the difference between that and osteoarthritis. Also, it's the distribution of the joints. With osteoarthritis, it can be one knee, one shoulder, a couple joints on the hand. But with rheumatoid arthritis, it's pretty symmetrical. It affects both sides of the body. With rheumatoid arthritis, when you have it in the hand, it affects these joints, the knuckles, and these. Whereas osteoarthritis affects these and these. So you really, when a patient comes with these involved, we really have to do a good history and exam and blood work to see if this is falling in a classification of osteoarthritis or rheumatoid arthritis. Now, part of, if you can attack this early and protect your joints early, you can have a better outcome. They say, for instance, if you carry a briefcase or a large purse, put it on a larger center of gravity, such as your shoulder, as opposed to all of your hand joints supporting that. So you may want to put items that you oftentimes reach for, instead of going up like this all the time, put them more at eye level where they're more easily reached. Why don't you come in? Have a seat. There may be certain types of clothing or shoes you may have to avoid. There go the heels, and I think we find out the hard way. So for our treatment, we want to I'm going to have to keep touching this because it'll go off if not. We want to do something about the inflammation, and we want to do it early. When I go way back in my training years ago, they used to say, wait until you notice that there is erosion or wearing away of the joints before you start a lot of these medicines. We no longer do that. Once we know that the patient has rheumatoid arthritis, we want to start our effective medications very, very quickly. Now, what you can do when you have inflammation is you can use the anti-inflammatory medications, Motrin, Celebrex, Aleve, but these only reduce pain and swelling to a certain extent. They're not going to do anything to alter the course or progression of the disease. And oftentimes in the beginning, we will resort to prednisone or corticosteroids. Now again, that's something we don't want to stay on long term because that can have bad side effects. It can weaken the bones, it can make you prone to infection, it can thin the skin, it can make you diabetic, it can raise your blood pressure. But sometimes we have to bridge that gap and put you on the prednisone in the beginning as we add our disease-modifying drug. Now, the disease-modifying drugs take time to kick in, and it's not immediate. If we suggest probably the mildest disease-modifying drug is Plaquenil. But it takes Plaquenil 4 to 6 months to kick in. sometimes patients will notice a difference in about 2 months, but normally it takes about 4 to 6 months to kick in. So I will explain to patients, give it at least 4 to 6 months before you decide it's not working. And if it's not working at 6 months, we'll try something else. And another disease-modifying drug is sulfasalazine, which is azolfidine. It's an old drug used to treat colitis. This works with rheumatoid arthritis, but probably the most popular one and the cornerstone of therapy, I would bet, is methotrexate. So if we're convinced with the history, I pretty much start the patient on methotrexate right away. I might try to get them functional by putting them on prednisone with the intent of slowly tapering the prednisone to eventually get them off. But we do find that methotrexate may be effective in certain instances. I did see a recent article in the last 6 months that said that, do you want a chair? Come on in. That said that if people switched from oral methotrexate, which they're the pills that you take, to injectable methotrexate, they may not have to go to the next level of drugs that we might be able to achieve remission. And I do have a good number of patients that manage just with methotrexate. They're off their steroids. They may take an anti-inflammatory. When you take methotrexate, you have to take folic acid because it can lower the folic acid from your body. And so you need to be, you might think, oh, now I have to take another pill, but it's you're keeping the mineral, the vitamin of folic acid in your body, which you need very much because low folic acids can affect the blood counts and that sort of thing. So then if the methotrexate, then I'll give the methotrexate a period of time, and then if that doesn't seem to be enough, and I might titrate the patient up to 8 pills, and you take it 1 day a week, okay? But when they're up to 8 pills, I tell them take part of them in the morning and part of them in the afternoon so that they're better absorbed. But still, they may not get absorbed, and then if we think, okay, the next step would be going to injectable methotrexate because then it will get into your system and we know it will be absorbed. So the physician might talk to you about doing it by injection once a week. And when you take it orally, again, it's once a week. Now, there are certain clues that give us an idea that you may not do well just with methotrexate. And we can tell this oftentimes with the type of presentation. We can tell by the rheumatoid factor or another antibody called CCP. When those are strongly positive, that portends this may be a more aggressive course. Over time, the patients may develop nodules, and that's a bad sign. That suggests this is going to be an aggressive disease. And the nodules aren't just these bumps on your fingers. That's a different kind. These are bony nodules from osteoarthritis. The nodules are on the elbows. They might be behind the foot at the Achilles tendon, or on the bottom of the foot. And these nodules suggest that, hey, this is going to be a more aggressive form. And so we may not want to wait for the methotrexate to get up to 8 or 10 pills once a week. We may want to move on to our biologic. And it's really been a huge revolution now with the biologics being available. Enbrel and Remicade and Humira all came out in the late 90s, early 2000s. So we've actually been using these drugs for 20 years. And so we do have a fair amount of experience that we've been able to put together. In the beginning, they used to say, well, you might get a malignancy later in life. These are immune modulators. They really go after the immune system to turn off the inflammation and and sometimes that alters other immune signals, and there are concerns about malignancy later in life, but it's more the category of lymphoma or leukemia. And again, just because of the haywire immune system that's going on with rheumatoid arthritis, if you don't treat it aggressively, you're at increased risk for leukemia and lymphoma too. So sometimes, it's not in the best interest to say, oh, I don't want to take a chance with this, because the chance of it occurring is so low that it can improve the quality of life. And now we've gone on to other types of biologic medications that those were the group called the TNF inhibitors, and there's others now. There's one called Cimzia that we find even safer to give to pregnant ladies because it doesn't cross the placental barrier. We give another one called Symphony, and you've probably seen these on television at different times, but there are a number of anti-TNFs that we can give. And maybe your pathway isn't the anti-TNF pathway. Maybe it's a B cell pathway, another kind of immune cell. Maybe it's a T cell pathway. And now we're getting into interleukin. We're finding that there's different chemicals that stimulate inflammation, and then it's this inflammation that is attacking the lining of the joints and eventually causing the cartilage to eat away and develop erosions and destruction. So we want to attack those, we want to have agents that counteract that type of inflammation. And so now you'll hear things like this is an IL-6 inhibitor or an IL-17 inhibitor. They're all different pathways of inflammation. And I think what's going to happen, and I hope I'm still practicing to see it, is that they'll be able to test a patient and find out what is the pathway of inflammation that is involved, and then you can pick the drug that attacks that pathway. I'm hoping that that's where I think that's where we're headed. There's even tests that we can do. The doctor will look at your SED rate and your CRP. These are indexes of inflammation, but they're not the only indexes. We're now finding you can have a normal SED rate and CRP, but there are 16 pathways of inflammation, and we now have a test. There's even, Linda is on the other side, who they run this test called Vectra. And that Vectra will give you a score that will fall into either an inactive range, moderately active, or high activity range. And the patient may say, look, my SED rate and CRP are normal. And now, yeah, but your x-ray showed that you're developing an erosion, and I'm afraid we don't have this under control. So we do the Vectra. And if the score comes out to moderate or high, yes, we need to do something more aggressive or change the way we're going. And so we have tests that help us predict this now, that put us in the right direction. But as far as treatment is usually, you start out with your anti-inflammatory, and then the prednisone or the steroids come into play, but then you want to get on something that's going to halt the progression of the disease. The steroids and the anti-inflammatory just cover up the problem and allow the joints to become eroded and the disease to progress. So I'll open it up for any questions. No, not necessarily. Sometimes patients do go into remission on these. The most important thing is preserving function, preserving independence. And so when you have the breadwinner of the family coming in and they're walking in like a stiff man and having stiffness in the morning lasting 3 or 4 hours, we'll throw on the prednisone to get them loosened up and movable as we pick the drug that's going to fix their scenario the best. And don't get discouraged. Sometimes we have to move from one class of drugs to another class of drugs. We'll usually try something for about 6 months. And we even have a drug called Cimzia, and they say that if you don't see a result by 3 months, you're not going to see it, move on. That's always very helpful, because then you don't have to wait. Most of the time we'll say, wait at least 6 months to see if this is going to do anything. And sometimes it can even take up to a year. But it was amazing when these first came out. I just could, when we were doing clinical research with Humira in the late 90s, when they were just developing these, and Enbrel came out, and Remicade infusions came out, and I'd see a patient, oh my gosh, you already have an erosion. And I shouldn't be saying this, but I actually repeated the x-rays 2 years after they were on treatment, and the erosion healed. I was just flabbergasted, and so, if you're advanced, it's not going to heal. It may just slow down the progression, but if you can get it early enough, then, and so we need to have PCPs refer early, instead of fiddling around with, throwing on this NSAID or that NSAID or prednisone and that sort of thing. We need to move on early. And then there are other conditions, like psoriasis can cause psoriatic arthritis that mimics rheumatoid arthritis, but it might be a different pathway of drugs that we use for that. And that's pretty much my spiel. So how can I help answer any questions or concerns? I don't think it's the methotrexate, unless he's developed. No, I don't think it's the methotrexate. I think it's the chronic wear and tear from the rheumatoid arthritis and the component of just getting older and losing muscle tone. How old is he? 81. And that's where physical therapy comes in handy. You want to try and keep your muscles in your joints toned, and do strengthening exercises. Go to the gym if you can, I think that's where physical therapy plays a big role too. No, in Sjogrens, you have primary Sjogrens and secondary Sjogrens. Primary Sjogrens disease is when, that's your main diagnosis, and you have certain antibodies that are positive in that, and you have a certain course, and that might respond to the earlier medications like prednisone and methotrexate, Plaquenil especially, because Sjogren's is kind of a cousin to lupus too, the primary Sjogren's. But then if you have rheumatoid arthritis or lupus or scleroderma, you can also have a secondary Sjogren's syndrome where you get the dry eyes and the dry mouth. And we approach that somewhat differently than the primary Sjogren's. And right now, in our clinic here, we have a drug that we are investigating specifically for Sjogren's syndrome. There is no drug specific for Sjogren's syndrome, and this would be the first, and so we have patients and it's very hard to get them in that study because you have to have the correct antibody profile. These patients have a positive SSA, and you have to have an abnormal lip biopsy showing that you have inflammation of your salivary glands. Now, the salivary glands are the parotids and the submandibulars, but our lips, especially our lower lips, are full of very, tons of minor salivary glands, and they'll do a biopsy, take just a pinch of that and do a biopsy, and if they're filled up with what we call lymphocytes, which are the type of inflammatory cell that is characteristic of Sjogren's, then we know that this is Sjogren's syndrome, or primary Sjogren's. Sometimes it's difficult later in life because we tend to become less efficient with our eyes and mouth. There can be some dry mouth associated just with getting older, or a lot of the medications that we use, a lot of the antidepressants and antihistamines and things like that have that side effect of dry mouth. But it's amazing because this new drug, it kind of falls more towards the lupus category of drugs. Well, rheumatoid arthritis and Sjogren's oftentimes are, yeah. And even scleroderma, okay. Sometimes you have secondary Sjogren's syndrome with scleroderma. Stress can set off exacerbations of our autoimmune diseases, and stress and maybe that surge of cortisol and everything, it can really set up a situation where the patients, sometimes following the high stress period, are banged, they just bottom out and are flaring. Well, and there's different types of cortisol now. There's a new drug called Acthar, which is ACTH. I don't know if the people saw 60 Minutes a couple weeks ago. They crucified that drug, although it was life-saving for infantile spasms in babies. 2 babies showed unbelievable, but it's a very expensive drug. I mean, it cost about to treat those babies, but now you have 2 viable children, and it was about $500,000. That's interesting. Right. But it's the GABA receptors that, when you take sleeping pills, it's working on those particular types of receptors to get lulled into sleep. The turmeric and the curcumin, there probably is a basis of that. I even have an anti-inflammatory recipe that was given to me by, she's an Asian Indian woman who consults with, I think, that holistic type of medicine, Ayurvedic, or AURY, it's a form of holistic medicine in Asia, and they actually, the lady who's in touch with them actually gave me her recipe. She had rheumatoid arthritis, and she had to go off Celebrex. There was a specific reason, and taking that away, she was afraid it was going to make her joints worse, and so she consulted this person. So it's 4 components. It's turmeric, Ganthoda, Ganthoda. I have the recipe. I can give it to all of you folks if you would like it. I'll go. You won't have to write it down. Fenugreek, Fenugreek, and ginger. So she suggested that you go to the Indian store and buy each of these dry ingredients. Well, they come in 7-ounce bags, and I went down to the Indian store down here, and they come in 7-ounce bags, and it's plenty. And I would take 1/4 cup of each of those, put them in a dry container, shake it up really, really good, and you're supposed to take 1/2 teaspoon and put it in a glass, add hot water. It's the hot water that catalyzes a reaction between the turmeric and the Ganthoda to produce another anti-inflammatory compound called piperine. And so this is all supposed to be and she contends that she just takes that and her methotrexate. Those are her only medications. And it hasn't gotten her off of methotrexate, but it certainly has helped her with the inflammation. So you have to take it first thing in the morning on an empty stomach before any other pills or food. And it probably does work for everybody. But I started taking it, and it tastes terrible. And it even made my teeth sensitive.
Oh, wow.
So I get a straw and I put it back to the back of my throat and I just slurp it down in the morning. But I thought, I'm going to solve this problem. I'll put honey in it and that'll make it better. No, you can't do that. You just have to do those 4 ingredients, no more additives. I don't know what happened. It sure made it taste better, and I thought I would like to take this down as a drink instead of bad tasting medicine. I usually end up, I put in maybe about that much water and I swirl it around, and then I add about that much more water so that I can drink it down fast. And because I take it out of my hot water tap. I have a hot water tap on my sink, and that's where but it's supposed to be hot in order to incite the reaction. You don't have to drink it hot. Yeah, and you can add cold too if I usually don't, once I get that hot and it's ready to go, I want to get it down so I can have my morning coffee. Yeah, sometimes I will kind of feel it in the morning, but it seemed to, that caused some irritation, but it seemed to help my GERD. It seemed to help it. I stopped taking Nexium. Yeah, for arthritis. And I noticed the change when I went away on vacation. I went to Europe, and I was afraid to fly with this stuff, and boy, I noticed a change when I wasn't taking it.